Welcome to Oncology Data Advisor. Today I'm joined by Dr. Jason Mouabbi, who is one of our editorial board members. And Dr. Mouabbi recently returned from the 2023 San Antonio Breast Cancer Symposium. And today he's here to talk about some of the highlights from the conference. So thank you so much for coming on the show today.
Thank you for having me. It's always a pleasure to be here. We just came from a very interesting San Antonio Breast Cancer Symposium. A lot of new stuff, a lot of exciting research happening in the field of breast medical oncology. Today, we're going to highlight some of the new advances for the medical oncologists. So during the meeting, there's a lot of basic science happening. There's a lot of research that pertain to radiation oncology, a lot of research that pertain to surgical oncology. But here we're going to focus about the perspective of the medical oncologist. What's new, what's exciting, what's coming to practice in the near future. Again, I'm Jason Mouabbi. I'm an assistant professor at the Department of Breast Medical Oncology. I'm also part of the editorial board of Oncology Data Advisor, and I'm the chair of the scientific advisor board of the Lobular Breast Cancer Alliance. As an outline, we're going to talk about three things. We're going to talk about the HER2CLIMB-02. We're going to talk about the updates on the MONARCH 3 trial, and we're going to talk about this new drug that was thrown to us. So the press release happened on Tuesday. The organizers were scrambling to add it to the meeting, and they finally added on Friday, so the last day of the meeting. So this is the INAVO 120 study. So very exciting stuff. Let's first start with the HER2CLIMB-02. So this was the primary analysis of a randomized double-blind phase 3 trial of tucatinib and trastuzumab emtansine, also known as TDM1, for previously treated HER2-positive metastatic breast cancer. It was presented by Dr. Sarah Hurwitz. Let's do a little bit of perspective why this study is important. So if you look at the approach to therapy for HER2-positive breast cancer, so first-line therapy is still the Cleopatra regimen, which is a taxane in combination with a dual HER2 blockade, trastuzumab and pertuzumab. Second line has changed in recent years with the emergence of the Destiny Breast 03, where the second line now is trastuzumab deruxtecan. Now, I kept it as second line, third line. It's mainly a third line regimen. It's the HER2CLIMB-01 study. This is the tucatinib plus capecitabine plus trastuzumab. However, some physicians are using it as second line therapy, especially in patients with brain mets, which is very relevant for HER2-positive breast cancer, because 50% of metastatic HER2-positive breast cancer will have involvement of the CNS. And at fourth line plus, here we have single agent chemotherapy plus HER2 directed therapy, either trastuzumab or margetuximab. But as you can see from this landscape, TDM1 has been lost. So if you remember, a few years ago, trastuzumab emtansine was the second-line therapy for patients with metastatic HER2-positive breast cancer. However, with the emergence of trastuzumab deruxtecan and tucatinib, it has lost its way, and nowadays we really don't know where to put it in our algorithm. So where does it fit? So we're going to see now. So this is the HER2CLIMB-02 study. It was for HER2-positive, locally advanced or metastatic breast cancer that progressed on prior taxane in combination with HER2-directed therapy. The study did allow for patients with brain mets. So they were randomized 1-to-1 to receive either TDM1 plus tucatinib or TDM1 plus placebo. And the primary outcome they were looking for was progression-free survival. If you look at the demographic and baseline characteristic of the patient enrolled, you could see that about 2/3 of them were also hormone positive, which really represent this population very well. If you look at if they had brain mets, about 50% did, and out of those, 20% had active brain mets. Now let's focus on how many prior lines of systemic therapy. So the median prior lines of therapy was 1. And if you look at those patients, most of them received prior pertuzumab, and a very minority of them received the prior anti-HER2 TKI. This was the primary endpoint, which was progression-free survival, and we can see here that the addition of tucatinib to T-DM1 improved the progression-free survival from 7.4 months to 9.5 months, with a hazard ratio of 0.76, and that was statistically significant. If you look at those patients of special interest, the patient with brain mets, you can see that the addition of tucatinib improved the PFS from 5.7 months to 7.8 months with a hazard ratio of 0.64. When looking at the common adverse events, so nothing out of the norm was seen here. We already are experienced with tucatinib, remember from the HER2CLIMB-01 in combination with capecitabine and trastuzumab. So we are well versed about using tucatinib, and we did see what's expected from tucatinib. So this is an increased incidence of the diarrhea and elevation of the liver function enzymes. So if we look at, again, the algorithm of how we treat, or the landscape of how we treat HER2-positive advanced breast cancer, so where I truly believe the HER2CLIMB regimen is going to come into place is going to be like a replacement of tucatinib plus capecitabine plus trastuzumab, where here you can use tucatinib plus T-DM1 instead of that regimen. But it's not going to change much the landscape of the current treatment. But I'm happy to see one of those drugs that for the longest time, it's been one of the best medication we had for HER2-positive make resurgence in combination with tucatinib. Now let's shift gear to the MONARCH 3 trial. So the MONARCH 3 trial, as we're gonna discuss in a little bit, it already met its primary endpoint about improving progression-free survival. However, we still did not have the final overall survival results. And at San Antonio, they also showed us finally the final overall survival results of the addition of abemaciclib, which is a CDK4/6 inhibitor, plus a non-steroidal aromatase inhibitor, which is considered an endocrine therapy or an anti-hormone therapy, as first-line therapy for hormone-positive, HER2-negative advanced breast cancer. This was presented by Dr. Matthew Gotts, and just a little bit of a refresher. So when we look about CDK4/6 inhibitors, initially we thought that maybe all of them are equivalent, but recently we started getting more and more data that maybe not. Maybe each one has special characteristics. And here I'm gonna just highlight, for example, two of them. The one in purple or blue, it's the abemaciclib. This is the one on the top, or Verzenio, that's the brand name. The one on the bottom is palbociclib or Ibrance. And you can see that their targets is a little bit different. So all of them target CDK4 and 6, but you can see that the abemaciclib have more targets, so it target other CDK. So you can see here it targets CDK7, CDK9, and CDK2, whereas, for example, Ibrance is more specific to CDK4 and 6. This is a busy slide, but here I'm trying to summarize all the different studies that look at CDK4/6 inhibitors in hormone-positive breast cancer. The Paloma studies are with palbociclib or Ibrance. The Mona Lisa studies are with ribociclib or Kisqali, and the MONARCH studies are with abemaciclib or Verzenio. Now, let's focus first on the Mona Lisa studies. All three studies have shown to statistically significantly improve progression-free survival and overall survival. If we focus on the Paloma study, yes, all those three studies did improve the progression-free survival. However, none of them improved the overall survival. And if you look at the MONARCH, so the first MONARCH study that came, the MONARCH 2, did statistically improve the PFS and OS. However, the MONARCH 3 did improve the PFS, but we didn't know if it did improve the OS. And that was the study. So again, this is just a refresher about the PFS result of the MONARCH 3 that led to the global approval. So here you can see it improved the progression-free survival from 14.8 months to 28.2 months, and that with an impressive hazard ratio of 0.54 that was statistically significant. And this is the overall survival, and that was the highlight slide of this whole presentation. So here you can see that numerically, it did improve the overall survival from 53.7 months to 66.8 months. However, unfortunately, that was not statistically significant. So looking back at the three drugs we have now Ibrance, which is palbociclib, we have ribociclib, which is Kisqali, and we have abemaciclib, which is Verzenio. The only drug that has in every single study that it undergone has statistically significantly improved PFS and OS is ribociclib. And that led to the NCCN guidelines as putting this regimen of aromatase inhibitor plus ribociclib, the only one as category 1 on their guidelines. Whereas the one with the abemaciclib and palbociclib are not categorized as category 1. All right, let's shift gear to the third study. This is a new drug called inavolisib, which is a PIK3CA inhibitor. And here the study looked at inavolisib or placebo in combination with palbociclib and fulvestrant in patients with PIK3CA mutated hormone receptor positive, HER2 negative, locally advanced or metastatic breast cancer. And the study was called the INAVO 120 study. And that was presented by Dr. Komal Jaberi. Again, let's put it in the context with a little bit of background. Let's look at the landscape or the algorithm of how we treat hormone-positive advanced or metastatic breast cancer. So the first-line therapy is a doublet, usually a combination of endocrine therapy, either an aromatase inhibitor or fulvestrant in combination with CDK4/6 inhibition. And then the second line, third line here, if the patient is still considered endocrine sensitive, we try to keep the endocrine therapy or change the endocrine therapy to something else and add another targeted therapy, either something like everolimus or alpelisib in patient with PIK3CA mutation. Patient with ESR1 mutation, we tend to do a different endocrine therapy called elacestrant, which is known also as an oral SERD. And if newly FDA approved, if patient has an alteration in the PTEN, PI3 kinase AKT pathway, we can also give them a target therapy called capivasertib. And in this line of therapy, if patient do have a pathogenic BRCA1 or BRCA2 mutation, we can consider giving them a PARP inhibitor like olaparib or talazoparib. Now, once patient become endocrine refractory, these are either the third line plus or fourth line therapy. Here we can do single agent sequential chemotherapy. Very important, we forget it a lot that if patient have high TMB or MSI high, regardless of the tumor type, they qualify for pembrolizumab, so even breast cancer patients, so keep that in mind. If patient do belong to the HER2 low category, they can qualify for a drug like trastuzumab deruxtecan, and patients who are HER2 zero can either receive sacituzumab govitecan or in the near future, datopotamab deruxtecan. But the question here, can we give first-line patient a triplet therapy? Can we move precision oncology more to the early setting instead of doing doublet, doing a triplet? To understand what we're going to talk about, it's very important to understand the estrogen receptor pathway. Yes, this is a busy slide, but we're going to also try to digest it together. The hallmark of the estrogen pathway is estradiol, and estradiol goes freely into the cytoplasm of breast cancer cells and bind to the estrogen receptor, which lead to a cascade, and it leads to cell division. So historically, the way we target that pathway is by inhibiting the production of estrogen or estradiol, and here we use an aromatase inhibitor to do that. However, you can also block it the other way around. So instead of blocking the estrogen, you can block the receptor of the estrogen, which is called the ER, and that you can do that either by selective estrogen receptor modulator like tamoxifen, or you can do it with a degrader of the estrogen receptor or downregulator of the estrogen receptor like fulvestrant. But parallel to that pathway that happened at the same time, and often it's the culprit for the resistance to the therapy that target the estrogen or the estrogen receptor, is the PI3 kinase AKT mTOR pathway. And this is usually activated by something like insulin-like growth factor when it binds to the insulin-like growth factor receptor 1, and it activates a phosphorylation cascade that lead to the activation of the PI3 kinase, which in turn will activate the AKT, and that will lead to unleashing mTOR Now, both those pathway eventually emerges into the cyclin D1 pathway, which is at the nucleus of the cell, and here it binds to the CDK4/6 proteins, and together they will allow the cell to go from the G1 phase to the S phase and allow for cell division and the propagation of the cancer. So we need more effective treatment for patients with PI3 kinase mutation that are also hormone positive, HER2 negative. And historically, this has been a very attractive pathway. However, it's been very hard to target due to the challenges of tolerability and safety of those drugs that target that pathway. Now, this new drug, inavolisib, it's a highly potent selective PI3 kinase alpha inhibitor that also promote the degradation of mutant P110 alpha, which may improve the therapeutic window. And in preclinical data, we found that there is synergy between inhibiting PI3 kinase and CDK4 and 6 in models that had a PIK3CA mutation. So the study looked at the patient, so it was a first-line study of hormone-positive, HER2 negative, advanced or metastatic breast cancer, and they looked at the cohort that did have a PIK3CA mutation. Patient need to have a measurable disease, and those patients, they also specifically chose patients with either primary or secondary endocrine resistance. So these are tumors that have progressed within 12 months of finishing adjuvant endocrine therapy, so from the early setting, or while they were receiving adjuvant endocrine therapy, the cancer recurred. And they were randomized 1-to-1 to receive inavolisib plus palbociclib, which is one of the CDK4/6 inhibitors, plus fulvestrant, which is considered endocrine therapy, versus placebo plus palbociclib plus fulvestrant. The primary endpoint of the study was progression-free survival. If we look at the demographic and baseline disease characteristics, if you can see here, above 40% of patients were premenopausal. So those patients received, some of them, ovarian function suppression to suppress their ovaries. If we look at the patient, there was very little bone-only disease, which I really commend them for that. I mean, those are truly high-risk patients because remember, in hormone-positive breast cancer, a lot of patients are bone-only disease, but these are patients, very little of them were bone-only. A lot of them had visceral metastatic disease. So 82% has visceral metastatic disease. If you look at what the patient received prior to receiving that line of therapy, a lot of them received chemotherapy in the early setting. Most of them did. If you look at the prior endocrine therapy received, 50% of those patients received tamoxifen. And that's one of the weaknesses, I would say, of the study, because those high-risk patients, the majority of them, in the US at least, will receive an aromatase inhibitor. So, but here 50% received tamoxifen and went straight on to receive fulvestrant in this study. So they missed a very important line of therapy, which is an aromatase inhibitor. The other weakness of the study is that not a lot of patients received prior adjuvant CDK4/6 inhibitor. So honestly, very little amount of patients, 3 patients in the INAVO arm and 1 patient in the placebo arm, which is also not anymore what we see currently nowadays, because nowadays most of those patients that are high risk will have also already received adjuvant CDK4/6 inhibition. This is the primary endpoint of progression-free survival, and here we can see that the median progression-free survival improved from 7.3 months to 15 months, so more than doubling. Very impressive, with an impressive hazard ratio of 0.43. When we have a hazard ratio of 0.43, that means about 60% of patients that received the INAVO drug had less chance of progression or death by just receiving that therapy compared to placebo. If we look at the subgroup analysis, all of them seem to benefit. I want to caution you with those patients that did cross 1. These were small numbers, so that's why I take them with great caution to say that those subgroup of patients did not benefit. Just keep in mind there were very small number of patients in those groups. But in general, everybody seems to benefit across the board from INAVO. Overall survival is not met yet. They have not met it yet. However, it's good to see that the separation has occurred and those curves are still separated. So this is reassuring. If you look at the overall response rate, it has improved by 33% by the addition of INAVO. And if you look at the clinical benefit rate, it also has improved by around 30%. Now let's put it in perspective. So this is the first time we see a target to the PI3 kinase AKT-mTOR pathway in the first-line setting. And here you can see that it's hard to really compare it to other drugs in terms of efficacy, because all the other drugs that target that pathway were mainly focusing on the second-line plus. But here you can see a little bit of comparing the PFS of those different agents compared to placebo. But safety is what's really we need to focus on. So although those drugs, are exciting, this is a very attractive pathway that we need to use. However, inavolisib does not come without its own fair share of adverse event. And here I really want to highlight about like the diarrhea, which is almost half the patient will experience diarrhea, and about 5% will have grade 3 plus diarrhea. The rash, 1 out of 4 patients will experience rash on this drug. The hyperglycemia, about 2/3 of the patient will experience hyperglycemia, and 6% will have grade 3 hyperglycemia, becomes diabetic. And stomatitis, which is ulcers in the mouth, about half of the patient experience that, and 6% had severe stomatitis. So yes, these are exciting stuff, exciting drugs, but they come at a huge cost. So it's really important to give them to the right patient and not everybody. Again, the side effect profile is comparable to what was seen with the other drugs that target that pathway. However, if you compare alpelisib, those side effects need to be more manageable. And case in point, if you look at the discontinuation rate, they were way less with inavolisib compared to alpelisib. 7% with inavolisib and 25% with alpelisib. So if we want to look at, again, the landscape of hormone-positive advanced breast cancer, we can see that now on the first line, soon we're going to get a new triplet therapy of fulvestrant plus palbociclib plus inavolisib in patient with PIK3CA mutation. So soon we're going to get a new line therapy for the first line, that for patient with PIK3CA mutation that progressed within 12 months of adjuvant endocrine therapy or while receiving adjuvant endocrine therapy, which is a triplet of fulvestrant, palbociclib plus inavolisib. Thank you.